Good evening, everybody. Thank you for being here. So today we have the third of the IPNA research webinar series, the pre-Congress. This is a pre-Congress series to the IPNA Congress of 2025, hosted by the Africa Healthcare Network. So this will be our educational webinar series number 135. So today, moderating the session will be Professor Dr. Dubisson, who is a qualified pediatric nephrologist and senior specialist at the Department of Pediatrics and Child Health at Tygerberg Hospital and University of Stellenbosch. Undergraduate studies done at Witwatersrand and subsequently to her DCH, FC Pediatrics and Certificate of Nephrology at UCT and University of Cape Town. Together with Dr. Christe, we have also Dr. Muslakhan Tene, who's a pediatric nephrologist, got an undergraduate degree at the University of West Indies in Jamaica and postgraduate degrees and Master's of Medicine in Pediatrics along with Adolescent Health at the University of Botswana and Witwatersrand University. And she's done an MPhil from Cape Town in pediatric nephrology. Was awarded the distinction during her dissertation, for her dissertation. And Dr. Muslakhan Tene is the first pediatric nephrologist in Botswana and currently the only one practicing in the country. She's a lecturer at the University of Botswana. Looks into both the public and the private institutions. Her academic interests encompasses pediatric acute kidney injury, nephrotic syndrome and genetics, and bladder studies, including urodynamics. So with this, I hand it over to both of you all to take over the whole webinar. Thank you very much for being here.
Thank you very much for having us this evening. And with me, as you know, Dr. Muslakhan Tene, and I am going to be moderating this session this evening. So over to you, Timbasile, to introduce our speaker for tonight.
Thank you, Lloyd, and thank you, Dr. Dubisson. Before I start, I just want to say on behalf of the fellows and the junior African researchers, I would just like to express our gratitude to the organizers for providing us with such an informative talks over the past we've done 3 sessions so far. And I think this will really help us in preparation for the IPNA 2025 so that we can also, as junior researchers, we can showcase our research. Just one house rule. Please feel free to just type in your questions during the talk and just drop it in the Q&A box. And if we have any topic that you are thinking of or you want to start any research, please also, we can share that at the end of the talk. So with that, I'm really excited to introduce our speaker for today, Professor Rulan Parekh. She is a professor who wears many hats. She's a senior academic at the University of Health Network and the University of Toronto. She's also a senior physician at the Sick Kids Hospital in Toronto, and she's done also a lot of work in the women's health as well. She has published widely, and she's internationally recognized as an expert in genetics. I think a lot of her studies is about genetics and how genetics relates or as a risk factor for kidney diseases as well as cardiovascular complication. She has extensive experience with NHI and funded studies using case control and cohort designs. And I think she's really perfect for today's talk. She's done a lot of work and she has led a lot of research both internationally and also in our area in the sub-Saharan Africa. She has received many awards and she has been elected in many international society. So with that being said, today she's going to talk to us about the why or the how of doing research. Thank you, Professor Rulan, and let's welcome Professor Rulan. Thank you, everybody. Over to you, Prof.
Thank you very much, and thank you for the kind introduction. And it's so nice to meet you both when I've seen you in virtually or at least talk to you by email at some point. So it's lovely to meet you. I'm going to talk today and really go over I'm just going to make sure my slides. Today, I'm going to talk about choosing the right study design in clinical research. And really, how do you do that based on the study question that you have? And what I'm going to do today is I'm really going to go over a conceptual framework, how you frame your study question, how you look at the study designs, and then the strengths and limitation of each design. And my hope is that each method, we're going to go through some examples. And I've tried to choose examples, not all that I worked on, but in fact, what other African investigators have done. So you can see the type of different study designs. So one of the most important things that I really try to go over with people is really asking, so what? Like, why should you do this study? And one of the things that's important is that you have to understand how your study question places it in the context of the population that you're looking at. And what are the things that you're trying to understand? Because sometimes when fellows come and talk to me about what they want to do, rarely do they actually have a clear study question. And so what I ask them to do is it a feasible question? Is it interesting? Like, is it going to change clinical care? Is it at least going to be more than what we know now? Is it novel? Is it ethical? And is it relevant? And this is called the finer criteria. And if you ask these questions, it's able to sort of poise what you do for your study question. What's really important is not to just reproduce what somebody else has done in one other country, because for all of you within the subcontinent, be it sort of in Asia or in Africa or in South America, I think what's important is that you can actually ask questions that are very relevant to your study population, and you have very unique risk factors. You have infectious diseases that are risk factors. You have different environmental risk factors. So don't think about just replicating somebody else's question and doing it in a different population. Actually think about what are the risk factors and what's the mechanism of disease and where you're practicing that could be really important, because even if the question seems so simple to you, the answers might be really important and help you address what you need to do within your country. I'm just giving this as an example of, I tend to do things in these conceptual frameworks. It makes me think more broadly. It doesn't mean I'm going to do all of these things. But what I did for one grant that I had in the US was, why do patients on dialysis end up having so much sudden cardiac death? And if I kind of work backwards, it's that we recognize that a lot of them have lethal arrhythmias. And so what leads to lethal arrhythmias is actually abnormal conduction and regulation. And so how could I measure that? And then I also recognize that you have to have vulnerable myocardium. So you can't just have, abnormal regulation, but if you've got abnormal regulation and abnormal myocardium, you then go to developing lethal arrhythmias. And what was important was we then took a look at what are the different triggers that could occur and what are the different risk factors. And so we were able to then study this in this very clear conceptual model and be able to understand that, in fact, lethal arrhythmias among those who are diabetic or those who are older are much higher, and they lead to higher incidence of sudden cardiac death. We were also able to show that, in fact, calcium phosphorus didn't have as much of an impact as we thought it would. And so independent of that, these measured arrhythmias actually show that you're at greater risk of sudden cardiac death. And so this is an example of a framework. Now, it could be that, in fact, it looks so complex. And this was a 5-year grant that we were funded in the US. And I think what's important to recognize is that even though you can put this framework out there, you're not going to do all of this work, but you're going to then try and be very specific about what your question is and make sure that you're only trying to identify 1 or 2 factors and make sure you thought through all of that. So again, this idea of a conceptual framework is really important for you to get your sort of your ducks in a row and think about what's the cause and effect, what comes first, what comes second, what leads to your outcome, and what are you actually interested in studying. It goes back to asking the right study question. And so when you ask the right study question, what's important to note is that it's clear and focused. So we're going to talk a lot about study design. You've got the right population, and then you can have the right analytical methods. Everybody tries to fix that at the time of analysis, but unless you get the right design, the right study population, and actually the right data collection, which I'll go over next time, no matter what statistics you add to it, you're never going to fix a bad study design, the wrong study population, or bad data collection, right? It doesn't matter what fancy statistics you add. You won't be able to correct it unless those 3 things are done correctly. So really think about what your study design is, really think about your protocol, and make sure you have really clear objectives. So I'm going to go back, even though you talked a lot about framing a question. I just want to go over it because it's important in how I'm going to set the context of how we sort of move forward. Whenever you frame your question in what's the population of interest, what's the intervention or exposure, what's the comparison, or what's another intervention you're comparing to, what's the specific outcome you're going to look at, and what's the time frame. These are important questions, and it's called PICOT, P-I-C-O-T. And this is a great way to make sure that every time you write down an objective, that you write it down using this PICOT framework. And then you're able to think about, okay, have I chosen that right study population? Have I chosen my question correctly? Because really, depending on what your question is really going to determine what's going to be the next step that you work on. And if you address all of these key points in how you're framing your study question, it'll make it much, much easier as you go forward. So this is an example, determine APOL1 is associated with steroid responsiveness and progressive kidney disease in children with nephrotic syndrome. So I've described my population in children with nephrotic syndrome. I've described my exposure, which is APOL1, and I've described my two outcomes, which is both steroid responsiveness and progressive kidney disease. And so you can see there that there's a number of things that I'm looking at. And then when I go to my hypothesis, I'm also being able to say, what are my comparison groups? Because we hypothesize that those carrying at-risk alleles for APOL1 will have a higher incidence of rates of steroid unresponsiveness. So I've already given you incidence rates. I already told you a little bit about my longitudinal study and looking at development of disease. And those will have faster progression. Again, it must be a longitudinal study to look at progressive kidney disease. And my comparison group is the non-carriers for APOL1 high-risk alleles. So that's an example of how in 2 sentences, I've been able to really describe everything for PICO, and I don't really need to do much else. And so it's really clear at this point that the type of study that I would do would be a longitudinal follow-up study where I would then be assessing APOL1 at baseline and then following patients progressively to determine steroid responsiveness and progressive kidney disease. So why is that important? Well, again, remember what you're trying to do is with clinical research is you're trying to test a research hypothesis that you have within a smaller study population that's reflective of your target population, and that you want to make what we call statistical inference and effectively causal inferences. So what we're trying to do is take the sample of the target population, make some statistical inference between exposure and disease association, and then ultimately that has some biological inference and causal inference. And so it's very important that we're able to test that hypothesis that we have. But we can't really, because we're not doing the mechanism itself and not everything is a randomized trial, we can't always prove causality. And so we're trying to test, can we say having APOL1 is actually associated with kidney disease? And we can only do that by doing a really good study design. And so that's what we're trying to do as we look for causal inferences. So these are the types of epidemiological studies. So there's descriptive, and I'm going to go over a lot of case series, cross-sectional or population correlation studies. And then you have analytical studies, which are non-experimental. So these are observational, case control or cohort, or a longitudinal study is another name for a cohort study, and experimental or clinical trials. And what I have in meta-analysis is this is when you do a meta-analysis of a whole bunch of published papers in that same type of study design, and that's called a meta-analysis. And so when I see published papers and I see what people are trying to do, and I'm associate editor for CJSON, I tend to see a lot of descriptive papers that are trying to be analytical. And in fact, it's okay to be descriptive, and there's some very good reasons why we should have some great descriptive studies. And then there are times that we move on then to observational, and there are times we move on to then experimental. And so the goal of the study design is really you're trying to minimize bias. Again, remember, you're trying to show that your study population is really reflective of the target population. So you want to make sure you don't have a selection bias. You want to make sure you collect information in a standardized way, then you've defined things beforehand of exposure and outcome. So you're trying to minimize measurement error, minimize recall bias, and you're trying to account for factors that are both associated with exposure and outcome, which is called confounding. And you want whatever study you have to be reflective of the larger population. And so these are points of internal validity or external validity. And it's important that when we review articles at the journal, we often review internal and external validity and try to make sure that there isn't too much bias that has affected the results. And we want to make sure that the study is done as much as you can to minimize bias. And so when we take a look at study design, this is sort of the hierarchy that we follow. But there are very clear times, and I'll show you some papers, when a case report is really important. A case series can be really important. And then you can build up your case as you go from a case series to cross-sectional to case control to cohort and to clinical trials. There are times when a clinical trial is the right thing to do. There are times when it's really best to do a case series and start getting to understand what the disease is. And I'll go over that example in a second. So what's important here in a case report and case series is that you basically are in the clinical setting and you're seeing your patients in clinic and you identify these random cases that have occurred, but you recognize in clinic you've now seen 4 or 5 of them. And that's a case series. Or you've seen a really unusual presentation and that's a case report. And what's important is that it's great for a novel description of 1 or more patients. It characterizes illness. It's really hypothesis generating. Its generalizability, though, is unclear because maybe it's spurious that you actually saw 5 of these cases. And what's also unclear is that you can't compare. So you can't look at risk factors and things to another group. And there's a publication bias because some people do a lot of case reports in series and some people don't. And so there might be lots of diseases that we still haven't seen because people haven't described them that well. And so this is a study that I just found, a case series, which I thought was great, of multisystemic inflammatory syndrome in children in Lagos. And what I liked about it was very clearly defined as a case series. And it's, again, this is a disease occurring within Africa, within Lagos, during COVID-19. And does this really happen or not? And again, when children were just being diagnosed with this was really important to understand what was going on. And so they did a retrospective review. They gave very clear timelines, which I thought was great. And then they went on and presented the clinical presentation, laboratory investigation at different times. But what's important is that, it's a descriptive study. So they could only tell us the frequency of what they saw. They could tell us therapeutic and supportive measures. And they could tell you, again, previous diagnosis prior to having multisystem disorder. So it's a good study that's really high level, descriptive. It can't really tell us all the risk factors, but at least can make us think about things that potentially what could we do next if we want to answer the question about why children have this disease. And so this is a great example of how we can sort of move forward by studying sort of a rare disease like this and looking at it from a case series point of view. And then if you did a cross-sectional study, you basically take everybody within your clinic. And now you're going to take those who are cases and those who are controls. This cross-sectional study is not a case control design. It's really important. I see that a lot, that people mistake that in papers when they present them to the journal. But what you really are describing is you're describing a cross-sectional study where you're defining what a case is, and then you're saying, and everybody else, I'm going to compare them to. So those who are defined to have a disease, let's say nephrotic syndrome, versus everybody else in clinic who doesn't have nephrotic syndrome. Those who have hypertension versus those who don't have hypertension. So the advantage for this is all of us could do this within our clinic. It's a convenient study population. It can be rapid, relatively inexpensive, but it compares the exposure and disease at the same time. And because of that, it's a chicken and an egg, and you don't know which one came first. But you can at least describe at this moment, they both seem to have this risk factor that appears to be potentially associated, but it's all happened at the same time, so I can't really tell. And so this was a great study by the Pediatric Nephrology group, again in Lagos, that took a look, now a different group, taking a look at the changing epidemiology of nephrotic syndrome. And what I liked about this was that, again, they defined in the cross-sectional study that they were going to take a look at 241 children in 2 centers, again, gave the time point. They were very clear about what they were going to look at. And they were really going to look at time of diagnosis and response to steroids and other immunosuppression. And I'm just showing one slide of the data that they had, but of the 241 children, you can actually see that if you were very young, compared to the 6 to 10-year-olds to the 11 to 17-year-olds, the majority of them had steroid-sensitive nephrotic syndrome, whereas only a smaller proportion had steroid-resistant nephrotic syndrome. And as many of you know, in nephrotic syndrome, it's often thought that there's a higher prevalence of steroid-resistant, but this study shows regardless of the age group, in fact, the prevalence of steroid-resistant is much lower than what had previously been reported. So again, this is a great cross-sectional study to then say, is this, this is not what we're seeing, and this is not what's been reported previously in older studies from Nigeria. And so, in fact, this is different than what was seen before. And so the next study that we're now doing with everybody in West Africa and also pediatric centers in South Africa and Cameroon is that we're following a group of children prospectively so that we can understand the prevalence, the incidence of steroid sensitive, steroid resistant, and actually see if some of them are treatment sensitive. And so again, this is the step that you take on in a study is you start with a cross-sectional, gives you some idea, it's hypothesis generating too, and now you can start moving forward in thinking about other types of studies. The next study we have is a case control. So in a case control study, you're defining your cases. Cases are disease. So those who've got kidney disease compared to those who were screened for risk factors, but definitely don't have kidney disease. So in H3 Africa, we're doing a case control design where our cases have kidney disease defined by their serum creatinine, defined by the protein in their urine, and the controls are specifically found in the population. And they specifically are screened for creatinine to make sure they don't have kidney disease, and are also screened to make sure that they have no proteinuria. So our cases and controls are defined very specifically. So this is different than your cross-sectional study. You assess exactly the same risk factors in both groups and see if there are any differences. And you can study many risk factors for a single disease like kidney disease. And you can also study rare disease outcomes that take many years, such as kidney disease. It's a great way to study kidney disease because end stage is relatively rare compared to diabetes, let's say, and it has a long latency over decades. So it may take you a while to get the end stage renal disease patients you need. And sometimes in a case control design, you can have fewer subjects. The problem is you're assessing your exposure and your outcome at the same time. So the temporal relationship, again, is not clear. You can't study rare exposures because you won't have a large enough population. And you really have to think about your controls. There's a recall bias also. And so potentially if you're trying to say, hey, were you ever exposed to lead? And you're asking them about exposure to lead, they may forget. They may not have remembered a job that they had. And so that's an example of how you couldn't assess somebody's bias for something that's relatively rare. So this was a study done in Addis Ababa, a case control study. And again, I like the methods and where they say it's a facility-based, unmatched case control. So they didn't match case to control. They did 253 children admitted to the ICU, again, given the time. And they did a systematic random sampling technique for the control group. And they took all cases consecutively. And so systematic random sampling meant that they basically took all the ones that didn't have acute kidney injury that came into the ICU, and they randomly sampled them to decide who were they going to take. So if they had 10 cases, they typically would take at least 10 control patients out of a group of maybe a couple hundred. But sometimes you actually match one case to 4 controls. And so that's something that they did. And then what they did was they then did a multivariable analysis to say which risk factors were associated with acute kidney injury. So I'm only giving you part of the data that was presented. But one of the questions that's really hard is when you list everything in a case control study of every risk factor that you've ever tested, the issue is that that's a really hard way to try and tease out what's a risk factor. So it's important that you try and be reductionist as much as possible and focus, again, going back to your conceptual framework. What are the risk factors do I really think are working together that would actually make sense to be associated? Because you could find some positive association by p-value, but that doesn't really mean that's biologically plausible, and it doesn't mean that it's really real. And so it's important that you think through ahead of time, what are those risk factors? So this is often people think of this about you're basically not quite handpicking, but you're basically going through trying to be selective about what you're finding and what you're reporting. And so sometimes at a journal point of view, we see papers like this, and it means that you're just fishing. And we don't want you to fish too much. We just want you to be much clearer about what you're trying to do in that project. And so here, this is just the top factors that were associated. But now you can see, instead of just showing the p-value or being descriptive in terms of the proportion of patients, they're now able to do a odds ratio and say, well, if I had sepsis, what's the odds of me having acute kidney injury in my cases versus controls? And now in your adjusted odds ratio, they adjusted for everything else that was significant. So sepsis was associated with acute kidney injury, hypertension, not heart failure, hypovolemic shock, and exposure to toxic medications. So what's good to know in these adjusted odds ratios, these are independent risk factors that are associated. An odds ratio actually gives you just, and we'll talk about it more in the next time we speak, is really, this really gives you the direction of association. This gives you the magnitude of association. This gives you the strength of association. And so you can feel confident that that's probably likely associated. So the issues with case control is that the cases are representative of everyone with disease, and the controls are representative of everyone without disease. If you get controls, sometimes you get hospital controls or community controls, and those could be quite different, right? Like for kidney disease, if you're going to get a community control that's in the healthy population, they've never been screened for kidney disease, but in terms they have kidney disease, but you never measured it, you could actually screw up your control population if you didn't test to make sure they didn't have kidney disease. And likewise, if you got a control population in the hospital, if you got everybody on the orthopedic floor who's broken a hip, they might be taking lots of non-steroidals or medication that affects their kidney disease. And so you might be sort of skewing your results. So you have to really think clearly about what your controls are. And then you match your cases and controls in a few factors. And sometimes we do that. It's very complicated. It's not complicated to do, but what happens is that the more factors you add, the harder it is to find controls. And so it's important that you think through, why do you want to do matching, age matching, sex matching, those kind of things. Collect data exactly the same way, often using validated questionnaires. And it may be the only way to study rare diseases. And it's hypothesis generating. And what's nice is that you can usually get smaller sample sizes and you're able to do a study a little bit faster. I talk about this a lot, the chicken and the egg. Remember that certain diseases can only tell you what, when you're exposed to something, what's going to happen to you 5 years down the road. And you can't do that in a case control study. And a lot of the studies that we initially did for APOL1 are related to understanding having a genetic disorder at the same time as having disease through a case control design. But it doesn't tell us if you have APOL1 over how many years does it take before you actually develop kidney disease. And in fact, there have been very few longitudinal studies. So it's important to think through that. There's lots of bias because the disease has already occurred. So you have to, again, go back to your conceptual framework. You can't estimate incidence or prevalence, and it's limited to one outcome because that's how you defined your case and control. So this is the study design that I think is sort of great for us as we move forward a lot in pediatrics, in pediatric nephrology and nephrology overall, is that we really need to understand in kidney disease, how long do people need to be exposed to an exposure before they go on and develop kidney disease? How long have you been exposed to diabetes or hypertension or a medication or having a disease before you're going to go on and get progressive disease and end up on dialysis? And so what's hard about this, though, is that it could take decades, especially in children, before they go to end stage. And so it's important that we follow people over time and we're able to actually see. So now we basically take a group that have disease and then we exclude those people. So if you're in my clinic and I've now got this light blue dots and you're already at end stage, then I'm going to exclude you from the study. I'm going to take everybody who's blue, who doesn't have end stage yet, and I'm going to follow them over time and try and define when do they go on and get end stage renal disease. What's good about that is that now I can follow them prospectively. I can look at the exposure that happened at the beginning when they were first enrolled in the cohort. And I can say, well, if you're exposed to diabetes over 20 years, your risk goes up 5-fold. And if that's an important factor to understand, then I'm able to give people really clear information about how long you were exposed to and how long it took you to actually go on and develop end-stage kidney disease. What's great about it is you can study lots of factors at baseline exposure. You can take a look at genetics, you can take a look at serological markers, you can take at variables that actually change over time. So you don't just measure them once, you can measure them multiple times. And so that's really a great advantage to the study design. The biggest problem is that it costs a lot of money. And it costs a lot of money because you have to evaluate those patients repeatedly and you have to follow them over time. And some people you can follow for 6 months or a year, and that's pretty easy. But if you're going to follow them over decades, that becomes a very impractical thing to do. And it's very hard. So if we were going to follow 1,000 children for nephrotic syndrome and we were treating them, and we knew that only 10% or less than 10% went on to end-stage renal disease, we would probably have to follow them 20 years before we actually got enough people to follow for understanding risk factors for end-stage renal disease. So that's really one of the complications, especially in pediatrics, is that sometimes we don't necessarily follow them longitudinally. And so some of the things that could be done within Africa is really thinking about What could be done with the adult colleagues? Because some of you transfer children at different ages. And so understanding that longitudinal outcome would be really important. So if I'm going to do what we call a prospective or a concurrent study, it means I'm following what your exposure was today, and I'm studying in the future about what your outcome was. You could still do a retrospective study that's not cross-sectional, but still do a cohort study because you follow your patients that you see in clinic, not everybody, but the ones that you decide that didn't have the disease you were interested in, but you're going to see those who didn't have disease, and then you could follow them over time, be it in your clinic or your hospital, your health system, or if there's available public data, you'd be able to say, are you exposed when you first entered at time 0? And now I'm going to follow you until today, and I'm going to see if you had an outcome. And that's called a retrospective study. And so this is where people get confused. There's a retrospective cohort study, and there's a retrospective cross-sectional study. And what's important is that you understand those differences, because you can infer certain things with a longitudinal study, and with a cross-sectional study, you're taking one time point and only looking at one time point. And you're looking at your exposure and outcome at the same time, whereas here you're looking at exposure and outcome separated, where the outcome happens over a period of follow-up. And here's an example of a cohort study, a progression of chronic kidney disease among Black patients attending a tertiary hospital in Johannesburg. And here they were able to do this longitudinal study of Black patients who had CKD, and they basically took their basic measurements, demographic and clinical data at baseline, and then they measured vital signs, Then they measured vital signs interviews at baseline and at follow-up. And they basically came in at study entry, so this is time 0, at 24 months, and then they followed them for 2 years. And they were descriptive, and then they were then able to take a look at multiple predictors. So this is an example of, these are the patients at baseline in blue. So they knew whether you had stage 1, stage 2, stage 3, stage 4, or stage 5 kidney disease. Now, remember, nobody's really got stage 5 at baseline because that's not part of the study criteria, because it's not a cross-sectional study. They were actually taking patients before stage 5 to then determine how long did it take and what were the risk factors for you to go forward. What's important here is what they describe at the end of the study was what happened overall was almost 50% met some criteria for progressive kidney disease. And this is how they defined it: sustained decline in eGFR, change to a more advanced stage, or greater than 30% reduction of eGFR in 2 years. And so it's important that people are able to see that moving forward. Again, it's longitudinal, and they're just describing overall prevalence, though, at the end of the study. And this is, again, don't expect you guys to look at this, but what I'm trying to show you is that they're now taking a look at what are the predictors of that long-term outcome. And they looked at everything. Some of those all of those risk factors were done at baseline, and none of these were repeated measures. They were only done once. And so are there any baseline predictors that are associated with poor outcomes? And what I would say is, again, when you do this laundry list, you have to be clear that you're not just, being selective about what you have. But if you had a very clear hypothesis that it was mineral metabolism that was associated, or cholesterol, or hypertension, then you could do this kind of search, but do this kind of analysis, but differently. If you thought that it was related to, and you were trying to understand multiple predictors, there are different ways that you do a predictive model, and that's when you get into the analysis, but you can use the same study design for that. So there are assumptions and advantages of a cohort study, in that you've got an open versus a closed cohort. And an open cohort means that you're just constantly adding to that cohort over time. And so I have an open enrollment nephrotic syndrome cohort that I continue to increase the number, and I have no fixed number that I want to get to, versus a closed cohort where it's very selective. I've got the certain time period, and I only want to make sure I get patients during that time period. Exposures can be ascertained at baseline and at many times after that. You can assess all sorts of outcomes. So not just kidney disease progression, but maybe cardiovascular disease, as an example. You can do it concurrently or non-concurrently, which is important. And what's also important, which is more complicated, but can be done, is that if there was a really rare risk factor that you wanted to assess, there's a potential for you to be able to do that within a case control or a case cohort design. So you can nest studies within a longitudinal cohort study. So it's important to recognize that cohort studies have great strength in lots of different things moving forward. And it's a great way to be able to do multiple types of studies. The disadvantage I went over is costly. It's impractical when the disease outcome is rare, but it is more generalizable depending on the study population. But it's important to understand censoring. So patients stop in the cohort as soon as they get the outcome, and then they move off. And so you censor them at the loss to follow-up, transplant, death, whatever it is, depending on your study. And so the last thing is clinical trials. And so, you know, we treat clinical trials as sort of the gold standard that we all want to reach. What's interesting now is there are some emulated clinical trials that you can now do within cohort studies. And that's a potential, I think, moving forward that may be really good within certain situations and certain populations. And so clinical trials have a great advantage in that you're truly testing causality, right? Does treating APOL1 actually have a beneficial effect in outcomes, and does it decrease progression? So a great interventional question. Randomization is important because you totally minimize bias, because you really have those who got drug versus didn't get drug and see if they benefit. And then you control the intervention. So you know what your dose is, and you can make sure that if there's a dose effect at the dose that you want, versus in an observational study, you just have to let the physicians do their normal usual care, but you can't control those things. And then it really has this causal inference. Again, it's logistical and quite complicated to do and run it well, especially if you're doing it for what we call FDA or EMA and IND, where you're trying to get a drug to market. But if you're going to test something that was already available, like let's say we wanted to test rituximab, there might be a way for us to be able to do that without necessarily having to make it so complicated. It's generalizable, and you really need to treat those who were randomized with the intent of going to one group versus another, not the as treated, as that leads to more bias. And so the trial designs itself are great, and that there's, for example, this one, the PIVOT trial, is a study. I'm just going to show you the study protocol, but it's a placebo-controlled trial of hydroxyurea for Ghanaian children and adults with hemoglobin SC disease. And what I really liked, and I'm just going to go over it here, is that it's randomized, placebo-controlled, double-blind clinical trial of hydroxyurea. So you already know the study design really clearly. You're going to recruit 120 children, 120 adults with this age, with sickle cell disease. You're going to be screened for 2 months and then randomized, and it tells you in a 1-to-1 to once daily oral hydroxyurea versus placebo. And that you're then going to be escalated on the drug, and you're going to be on it for up to 4 years. So all of that really goes back to describing from the PICO, I know my population, I know my intervention, I know my comparison group, I know my outcomes, I know my study design, I've got everything, and it's in just a couple sentences. And so your method section for all your papers or all your studies you're thinking about kind of gets reduced to these few sentences, but it's crystal clear what they're going to be doing. And what's also important is that there's safety outcomes for the trial, but they've also got efficacy outcomes, and they're really clear about what they're going to look at. The first 12 months of randomized treatment, they're going to take a look at change in hemoglobin, fetal hemoglobin, intracranial velocities, and cerebral oxygenation. And they have a whole bunch of other ones and some exploratory ones. But what's important is that they very clearly have stated up front what their outcomes are, and so that they're not sort of mining the data to find anything. And this is an example then of all the studies that you would do. You could do this for both an observational study that you're doing prospectively versus retrospectively, and what you do for a clinical trial. In a clinical trial, though, you have this -2, -1. This is your screening period. Then you get enrolled at your time 0, and then you follow people prospectively. And this is the way that they've standardized everything that they're doing for everyone. So recruitment and selection are clear, and it's really important that you understand how recruitment's happening, again, so that there's not a bias. You get random allocation, so somebody else is doing the random allocation, and it's important to know who's blinded. Important that you're very clear about your outcomes, clear about your follow-up. And it's important that your groups are balanced from study initiation and throughout. And things like this are really big and difficult. One of the kidney trials initially, about almost about 10 years ago, that was looking at one of the phosphate binders, was clearly balanced at the beginning, but became unbalanced over time because the physicians started taking people off study. And so it's important that we recognize what affects the balancing. Length of follow-up is important, always have early stopping rules. And then it's really important that there's public and transparency in what we think we're doing. And pediatric trials often do not get reported well. And so it's really important that we do this much better. There are multiple types of RCTs, parallel, crossover, factorial. And I won't go over these in big detail, but it's important to recognize that if you do a parallel design or factorial, you need a much larger sample size. An example is the HEMO trial, which took a look at low flux versus high flux, KTOV, and was able to do these large, you had these large groups that had to occur, so thousands had to be recruited. But if you do a crossover trial, for example, the DASH diet, showing that a dietary approach to stop hypertension diet, that was a crossover trial in less than 200 patients, which you were able to show that there was a significant benefit. And so it's important to recognize that certain trial designs, you can actually have a much smaller population, and that continues to get better because there are some new adaptive trials, especially in pediatrics, which I think will be the way we'll need to move forward. Advantages, cause and effect, important for clinical and public health policy, and it minimizes bias and confounding. I sort of went over these before because you have very limited research questions. You're unable to study rare diseases. It's difficult to recruit sometimes in the trials because it's a lot of work. Patients don't want to come that often, and they get tired of being within the trial. And sometimes the randomization gets screwed up. And that's really tough when that happens. The last thing I'm going to go over, because then it'll give us a good 15 minutes for questions, is meta-analyses. So meta-analyses are really when you do a systematic review of cohorts or clinical trials, and you're going to pool all this data from the multiple studies that have been done that you couldn't infer. For example, does giving a statin actually benefit patients who've got kidney disease and reduce the risk of kidney disease progression and cardiovascular disease? And so even though there were some positive trials, there were also some negative trials. So you pool those all together, and then you can have a larger sample size and detect a true effect. And it's a great way when you're doing a guideline to think about how do you pool that data together to give an overall risk. The problem is that these individual studies are badly done, then maybe it's not so great to pull together. And so that heterogeneity may be too much and you can't really combine them. This is just an example that we did, taking a look at all the studies of childhood nephrotic syndrome in a systematic review. We were hoping to do some meta-analysis of treatment effect, but the majority of studies were cross-sectional. So at most, all we could do was describe prevalence. And so we did a search looking at Medline, MBase, and African Journals Online and WHO Global Health Library, and we were able to find a number of papers, which I'll show you, specifically taking a look at the primary outcomes of steroid response, biopsy, and we were clear about what we wanted. We wanted to pool data and look at individual proportion across regions and overall. And we couldn't really do a full meta-analysis because there weren't any longitudinal studies. So what we did was we just grouped studies, and there were many studies overall, I think 61 papers. And we basically took the minimal amount of data that we could get that we thought was robust among all the different studies, describe how many had steroid-sensitive nephrotic syndrome, steroid-resistant nephrotic syndrome. We were then able to give the prevalence of it, and then we were able to give a pooled estimate of what we think they had, and then give an overall pooled estimate that 64% of children who have nephrotic syndrome have evidence of steroid-sensitive disease, and then 34% have evidence of steroid-resistant. So this is an example of when we now take a look at this, we can take a look among 61 studies that were done among more than 7 different countries across 7 regions. We're looking at 5,900 children overall that were given steroids. And this is the proportion that were differentiated in steroid resistant and steroid sensitive. And so it's a way to get a larger population. And so much like Chris Ezobar's study from Lagos, which gave a little bit higher amount that had steroid sensitive, we're getting pretty close because we now have a larger sample size. So what's great is both the meta-analysis and Chris's studies show pretty much maybe studies in Africa that steroid-sensitive nephrotic syndrome is actually much more common than steroid resistance. So I hope I've shown you today that you have an optimal study question design during the planning phase of the study. You use the finer criteria to really think about your study question. When you frame your study question, you write it out. You want to really fill out the PICO framework, right? And then you can choose the study design based on the question, your conceptual framework, and the population. And what I would urge all of you is planning, planning, planning. It's really important that you don't just jump in and just start collecting data, that you really plan it well and think of it ahead of time, because you don't want to go back if you don't need to, and you really want to go forward. And I'd really like to make sure that you guys are going forward so we can all see you in 2025, which I'm excited about, and think about all the progress that you're going to make. So I'm going to just stop now, and maybe I'll...
Thank you very, very much. But that was really, I must say, I was trying to think like I have to ask you a question now, but I was so enthralled in what you said. And it was really, I just want to ask you if you can think back many years ago when you just started off as a very young green researcher. What was the thing that helped you the most? Following the criteria, following your big question, just thinking it through the whole time and starting something small and building up, or jumping into the deep waters and swim?
I think it depends on where you are and what you're doing and what you think is the biggest issue that you're facing. Many of you have, trained elsewhere, and then you come back sort of to your home country, and you've seen lots of things in terms of dialysis and CVVH and PD and all those kind of things. But I always think, what's the burning question in your community that you need to address? That's really important. And it could be that doing a simple cross-sectional study is a great way to start. Because if you suspect, for example, in the most recent series that we did, and it included global health and many projects from Africa, there were many studies that were cited talking about COVID, but even looking at, I thought, plant-based medications that people were using to treat COVID. And that was actually very common in the DRC. And so what was interesting was they did a lot of really important case series and then did a case control study. And so that was an important question that was relevant to their population that they were then able to do. And so I think that's what I would think about, is that you should start with something that you think is really important, that's affecting your community, that you want to address, and then probably start with a cross-sectional study first and really start thinking through it so you can get an idea about how you're going to measure it, how you're going to ascertain it, what can you do within the data that you have and the resources that you currently have, and then slowly build up. Like if somebody said to me, well, I think we should do APOL1 in a clinical trial, I'd say, okay, let's partner with the pharma company and do it that way. But I think I wouldn't have people jump to a randomized trial first. I would really start thinking about what you want to do that's local, and probably start with a cross-sectional study, and then really start thinking about what would be the next thing that you could do. And I think, I see Robert's on here from Uganda. There's a huge amount of great work happening. And one of the things that's great about a longitudinal cohort study is you can add things as the study's going along. And so there's lots of projects that are ongoing. And if there's ways to collect a little bit more data, for example, in the studies that they're doing in measuring GFR, that would be a great way to add to that so that more junior people could have access to it. And that's what I've done a lot of. Like I would say that my success is based on the great students that I've had who really leveraged all the data that we've collected in our cohort studies.
Thank you very much. I see Valerie has asked a question that she put in the chat, and she said, brilliant talk. Yes, definitely. What study design would you suggest for people to think about as feasible studies to meet the IPNA abstract deadline? And could you give some examples of research questions, or could the audience suggest some that they might be thinking of? For your answer, please, anybody who has a question, please put it in the Q&A, put up your hand, put it in the chat, and we'll go through it. Thank you.
There's, again, I'd say the cross-sectional design would be the easiest to do. Things that I think people could do that I think are not done, and there isn't that much data, is there's a ton of lack of understanding of the prevalence of hypertension in children in Africa, across the sub-Saharan Africa. And I think if we're able to understand what that was, how many young adults also in their 20s are there, what's the influence of diet specifically and activity related to hypertension. I think hypertension, for example, to me is something that's so common, the interaction of hypertension and sickle cell disease, hypertension with diet, inactivity. I think there's a lot to be said for studying the common diseases. And those are the kind of things that I would think would be really relevant to be able to take a look at. If you want to take a look at risk factors for hypertension, that would be an example, or risk factors for proteinuria in what patients are presenting at, or chronic kidney disease in the young adults, like less than age 30. I suspect that the prevalence changes with age. And so do the young adults actually have a preventable disease or something that we could intervene on sooner? And I think we need to think through that, because like in North America, you know, the mean age of going on dialysis is actually age 65. And so many of the studies are focused on 65 and older. And what we're not doing is really focusing on the young adults, where there's a lot of preventative disease and they have a lot of glomerular disease, for example. Another thing is lupus. People say lupus many, many years ago didn't occur that often. Whereas I think in the study we did as the systematic review, lupus is really common and I think should be studied. And is there a way for us to do that well and think about how they're being treated, and what could we do that are African specific solutions that aren't necessarily, that are different than what are the current guidelines. So those are just some examples.
Hi, thank you, Prof. I think as you are talking, there are just several things that I'm thinking about. So I'm from Botswana, so our population is quite very small. And sometimes when you try to do a study and people look at the population size of like 20 compared to a population size with a nephrotic syndrome, for say, but 20 is quite big for my population of 2.5 million as well. So does population size, that's my question, really matter in trying to come up with a study? Is it bad that I'm having a nephrotic syndrome study of 25 and somebody comes with a nephrotic syndrome study of 200 or so?
I think there it depends on what your question is. So if you're going to describe 20 children with nephrotic syndrome and prospectively what happens to them over time, and then you can describe, for example, like 20 children and they're like, what happens if they get malaria? What happens when they get certain viruses? What happens? Like nobody else has done that. And so we published with 40 children, I think, with IgA nephropathy a few years ago, and C. Jason with Damien Noon. And, you know, we had great longitudinal data. So we were able to show changes over time. And so what I think is important is it goes back to what's your question and making sure that your question adds something new that's relevant. And I think that in nephrotic syndrome, like we don't know what to do with infections like malaria and infections that you might get in schistosomiasis. So what happens with nephrotic syndrome when you're on steroids, when you're on cyclosporin, like who knows what you do with that? And because malaria is so common, how do you actually manage that, right? And so that in itself is a great question. And so if you could address that in 20 people that you followed over a couple of years, that has great utility and it's really important, right?
Yeah. And then the other things are just ideas that I just ran through. So because pediatric nephrology was almost non-existent until I graduated, which is about more than a year ago. So what I've been seeing a lot is a lot of genetic kidney diseases. So can somebody just, can I just maybe do a study just to describe, because I'm seeing a lot of primary steroid-resistant FSGS. I'm seeing a lot of congenital and familial FSGS within. You'll have a mother who has 3 kids with nephrotic syndrome. I'm seeing hyperoxaluria, and it's a type 1. I was able to do a test. It was a primary type 1 hyperoxaluria, and they are in a certain area. I'm seeing a lot of polycystic kidney disease. Can I just, because I think one of the challenges in Africa is actually getting the definitive diagnosis of this genetic kidney disease. So can I just do a study to describe the genetic kidney disease that people think may be rare in my setting, but not something like that? Can I?
Yeah, so I think, you know, what would be interesting is you would be able to describe sometimes you don't have a population to describe compared to, right? So instead of describing it just yourself, what you're going to do now is you're going to describe it to the relevant literature that's available out there. So you can say, well, in North America, this is the most common cause of kidney disease. This is how it's broken down. And this is what it is in Canada or Europe or Australia, wherever you want. But in our population, we actually see 75% have some genetic causes. So like, why would that be that you have 75% have genetic causes? It's important to understand in relationship to what other people have been describing. And so that's always the question, though, is that a selection bias, again, of your population? And I think part of it is you're the first pediatric nephrologist in Botswana. So for you to say, in my first year experience or in my first 2 years, this is what's being referred to me, is this reflective of what other people are seeing, or is this actually unique to Botswana? So why is that important? Because you then need to talk about, like, what's the supports that you need? What's the counseling you're going to give? What do you need a genetics counselor? How are you going to counsel families? And those are the kind of things that you need to think about. I think it's, I think it becomes very, again, depending on what your question is and what you want to do with the information. I can almost always come up with a question. I think it's just a matter of making sure that it fits what you're able to do and that you're able to compare to. But don't think that you can't look at some historical control or literature or describe in comparison to another population. More, it's qualitatively, but at least you're being able to give some context to your findings.
Thank you so much, Prof. Thank you.
All right, no problem. I'd also say partnering with people is important. So potentially, like, if you want to partner with me on that FSGS, I'm like happy to talk to you about that, right? Like, there are ways that we can work together to make sure that you can maximize what you do, right? And you maximize. So partnering also with people within the region, I think, is also really important.
There's a question from Amos Kibet. I think Valerie has put a few comments in the Q&A box about genetics. Was the comment from moderator from Pretoria last week. And you could also join forces, maybe not with IPNA, but think in the long term. And even if you just, the other comment of hers was, even if you describe the diagnosis of all the children coming to your clinic in a various amount of months and compare two different areas.
Yeah, so I think that's what we had talked about, right? Comparing in different regions and taking a look at it. I think that's always a good exercise. Maybe going back to the genetics question, there are ways to get genetic testing done, and sort of we could talk about it. And there's a company called No-3 who we might be able to come up with some collaboration with them. I think the difficulty for the genetic testing is there are genes that you're going to act on and you might do something about, and there's some other genes that are just nice to know. The example I give is for FSGS for genetic testing, is that there are some that may still be treatment responsive. And so having a genetic disorder doesn't necessarily mean that you're going to progress to end-stage renal disease and you should stop all therapy. And so that's just something we need to think about, because there are single gene disorders and there's probably polygenic disorders that lead to end-stage kidney disease with FSGS. And so I think there's still a lot to come forward. So the guideline might say do genetic testing, but all those genetic tests, just so you know, in all those populations were done in a European or American or Middle Eastern sort of populations. None were within Africa. And so I think it is asking, like, are there single gene or multiple gene disorders that are related? And I think that's a very important question that we should ask as a group. And hopefully as part of H3 Africa, we'll do it. But I am concerned that if you find a genetic test that's abnormal, people are saying, well, stop therapy. That may not necessarily be the right answer. Not for all of them, I think. So we'll have to see how that pans out.
I'm just going to, do you think it is a good idea to look at the adult population? And I think maybe you touched a little bit on hypertension, but look at diseases that adults are describing in your community and looking at your own, and then see, like, is there something that we can do in the pediatric population to actually prevent, decrease, help the health within our pediatric population so they do not end up like that, and then look at that in your own group.
Yeah, I think always, like, for example, if you can show young adults were at risk for, they had significant hypertension, and then what you need to do is actually perhaps screen them at, during school age, then the question is, again, maybe doing a school-age cross-sectional study to take a look at what's the prevalence of hypertension among school-age children, so that you could think about what are the interventions you could do before they progress. Because we know hypertension may be one of the biggest contributors to end-stage kidney disease in the population. But it'll depend on, understanding the pie chart about what are all the causes of kidney disease in different age groups in your region, and then saying, okay, well, maybe hypertension is one of the biggest risk factors. Because most of them have, unknown cause of kidney disease. And so perhaps that's what we need to address. So I think, yeah, it's totally relevant to also partner with your adult colleagues and to really think about what are the young adults at risk for, and then what could be preventative.
It was one question. How would one go about best to form a research cohort within AFRAN where people interested in doing research can actually post questions, and then the group actually helps out in terms of defining the question, formulating a right study design, going about data collection, and teaching the younger generation as to how to go about doing. A lot of them don't have formal training in research, and sometimes affordability is an issue. Even if they are doing very well, would like to go for a master's, it is an issue. So how would actually go about doing, and it's a good initiative that you've had this research webinars. It's a very, very good idea. And I know you've had some ideas about, mentoring people. So how could we actually put something together to do something like that? Thank you.
Yeah, so in the States, there are, and Canada and Europe, there are all these different collaboratives that work together to actually address a question. Most of them have taken significant infrastructure building to be able to do that. The one example that we can talk about for H3 Africa is that I think going forward, hopefully in our grant submissions, we can talk about, doing larger studies and doing ancillary studies to allow people to be able to use that framework. So we can now follow those thousands. We're hoping to get to 1,000 children with nephrotic syndrome that we're going to follow longitudinally. And the question is, how could we add other groups to that, which could then do some of the data collection also at their site, see what's going on at their site, being able to learn from it. And then definitely it has to be made available to younger researchers. So one of the things that I've tried to do with some of the cohorts I've been involved in, and I've done it quite a lot when I've been able to be in charge, but sometimes it varies depending on how big the collaborative is. But that there's always a junior person who's the first author, who then is taking responsibility to do that project and to take that forward. And I think that's a great way to train the next generation, is to make sure that they have access to the data, have access to learning, and have access to somebody to help them do that study design. And so it's, it's a way for us to think about co-curricular design and also mentorship. And then how can we do that to scale it so that more and more people get mentored, and so we can have more and more people asking those kind of questions.
I see there's a question from Sharifu Janga. The first question, or part of the question, is how can you, I think, come up with inclusion and exclusion criteria in the study? And the second one, is it important to have conceptual framework to the study, and how can you differentiate from a theoretical framework?
Okay, so if we do an inclusion, exclusion, again, it goes back to what's your study question? What don't you want to muddy the waters with, right? Like, I want to study hypertension, so if they have diabetes, I'm going to exclude them from the study. So you just have to be, again, really clear about what your question is. So you're very clear about what you're going to include and what could be a confounding factor that you want to take out of that. But you have to balance it from how much is it going to affect recruitment? Is it really a problem? Is it difficult because everybody with hypertension has diabetes too, or every diabetic has hypertension? And so you have to really think through your study question, and then make a decision then about your inclusion exclusion criteria. But there is a balance in terms of recruitment. The conceptual framework is really your conceptual framework versus a theoretical framework. So the theoretical frameworks are mostly applied to qualitative studies, which I didn't go over at all. And you can do qualitative studies that have different frameworks on how do you approach asking those questions, and how do you qualitatively assess that theory. In the conceptual framework, it's really trying to go cause and effect. What do I have to get exposed to, and how do I get disease? And what are all the risk factors that may contribute me to get kidney disease? And then thinking about how you put those into order, and then how you actually study them is sort of more the conceptual framework. And mostly the term theoretical framework is applied to mostly qualitative studies. which I didn't do any justice to or talk about at all today, but clearly another area that we could do a lot in.
I think I'm going to say thank you very, very much. It was really lovely to listen to you and learn a lot more. And I see Sharifa has just posted a thing, how reliable and validity is important in the study.
Oh, it's really important. And I'll go over that in the next time when I talk about data. But validity is incredibly important. And so is reliability, right? So if you're going to do a measurement and think of a bullseye, you want that measurement to be as close to truth as possible, which is the middle of the bullseye. But you want to make sure every time you measure it, it isn't random places across the bullseye, but in fact, you're reliably hitting the bullseye every single time. And so there is a difference between reliability and validity. And we'll get into that really when it comes to data.
Thank you very much, Dr. Parekh. It was a wonderful session. I think it's extremely well covered. It is recorded and it will be up on YouTube in the next 3 to 4 days for sure. So for everyone to listen, this will be the third of the series and all the 3 will be up. The first one's already up. The second one should be up by tomorrow. And the third one will be in another 2 days' time, 2 to 3 days' time. I think it was a wonderful session. Thank you very much.
Thank you so much for having me. Thank you.
And I'm sure that we are going to hear more of you in the next sessions to come. And I'm also grateful to Dr. Crystal and Dr. Timbasili for being there to moderate this session. Thank you very, very much. And we look forward to all the other research webinars as well, which will actually help educate a lot of people. And it will also be on YouTube. And we probably put it together on YouTube so that you have the whole series together as a separate sort of YouTube channel and go from there. So thank you very much. And we hope to continue with these sessions. And thanks to Dr. Ashton and Dr. Vignan for actually putting this together. And it's a great idea, actually. Thank you very much.